like to thank Dr. Russell Margolis for his opportunity, his busy time. So it's an honor to have you here with us. It's really a pleasure, and very nice to have your presentation. He's going to talk to us about new onset schizophrenia, dilemmas of diagnosis and treatment. Dr. Russell Margolis is a professor of psychiatry and neurology in the Department of Psychiatry and Science of the Johns Hopkins University School of Medicine in Baltimore, Maryland. Dr. Margolis received his undergraduate degree from Princeton University and his MD degree from the Johns Hopkins University School of Medicine, and completed residence training in psychiatry at the Johns Hopkins Hospital. After a fellowship in neurobiology at the National Institute of Mental Health, he joined the Johns Hopkins faculty, where he is now serves as a clinical director of the Schizophrenia Center and director of the Laboratory of Genetic Neurobiology. He treats patients and provides consultative service at the Johns Hopkins Inpatient Schizophrenia Unit and the Johns Hopkins Bayview Early Psychosis Intervention Clinic. His research interests include the pathogenesis of Huntington's disease and related monogenic neurodegenerative disorders, the phenotypic features of recent onset schizophrenia, the application of advanced neuroimaging to understand brain circuitry in schizophrenia, and the application of neurogenetic techniques to the discovery and characterization of genetic risk factors of schizophrenia. Russ, thank you so much for your acceptance. It's a pleasure to have you in our department. The word is with you. Thank you.
Thank you. Well, I appreciate the very kind introduction, and it's a pleasure to return, even if virtually, to back to Brazil and the Federal University in Sao Paulo. Let's see if I can share my screen, and let's see how this works. If we're lucky. Yes. All right, and we should be able to do that. And we should be able to go like that. Okay, how does that look?
It's cutting a little bit. I don't know if it's in the full presentation mode. Now it's fine.
That's okay.
Perfect.
Okay, as long as it's okay. Well, it's again my pleasure to be able to speak about new onset schizophrenia and some of the dilemmas that clinicians face. I fondly remember my last visit, or maybe it was the visit before that, to Unifest, and hosting by Dr. Mari and Dr. Gadelha and Dr. Bressand, and getting to meet a number of residents and other faculty member, and learning about what the really great activities going on. And I feel in some ways I'm speaking to a very expert audience, many of whom probably know more about this topic than I do. So at the end, please speak up, let me know where I've made mistakes, and we can hash things out a little bit. As we have to do in US talks, we need to do our disclosures, and I don't really have any commercial disclosures. I do think that it's important to say that I'm somehow under the influence of various parties at Johns Hopkins, though no one likes to talk about that. There's the picture of Johns Hopkins, who founded the place. He was pretty rich. And here's Michael Bloomberg, who's really rich and is really supporting the university. I'm pretty confident we're going to become Bloomberg University pretty soon. You know, how many billions does it take to buy your name on? He's already the named on the School of Public Health and various scholarships and who knows what else. Whenever there's a big anonymous donation, everyone knows where it came from. And of course, like everybody else, I'm subject to all the various rules and policies of our leaders, who I think this group I learned about has some relationship to our leadership sometimes, though that's being a bit unkind. We actually have pretty good folks. So I will talk about some off-label use of agents. And here's the objectives of this talk. Again, this is a habit from the requirements for talks in the US. So we're going to talk about the diagnosis of schizophrenia early in its course. We're going to talk about the diagnostic uses of MRI and genetic testing now and in the future. And hopefully we'll think about some ways to improve outcome in schizophrenia. And here's the basic outline. I want to talk about the recent onset of schizophrenia from a diagnostic standpoint and the various dilemmas that are still unresolved about how to approach the diagnosis of schizophrenia early in the course. Then some of the dilemmas of treatment of schizophrenia early in the course. And then how I think we can best begin to consider reconceptualizing our diagnostic practices with hopes that that will lead to an improvement in our diagnosis and treatment going ahead over the next 10 to 20 years. So let's start talking about the dilemma of diagnosis in a construct. And remember, this is a construct that arose 120 or so years ago that's really entirely clinical. If you think about schizophrenia, it's sort of like talking about dropsy in the year 1900 or late 19th century, where it's just fluid overload. And now we know that there's fluid overload and electrolyte disturbance and all sorts of reasons. And the subtypes make a huge difference in treatment, prognosis, and the like. But at the time, it was lumped together as one illness for which the most common treatment was bleeding, which probably helped a little bit for a while. You're fluid overloaded, losing some blood works until you lost too much. And I think we're somewhere at about that stage in thinking about our disorders, but we have a path forward, which we will get to. So schizophrenia it's clinical. We don't have a schizophrenometer. We don't have a hallucinometer. We don't have ways of objectively measuring symptoms, though one could argue that various devices that measure activity might help. But our diagnosis is really based on the clinical history, the mental status examination, and making sure the patient doesn't have something else that we ought to treat directly. So in thinking about the mental status examination, so first of all, there's the usual aspects of the mental status examination: the patient's appearance and behavior and speech and thought processes, their mood, affect, volition, energy, etc. That's the standard part that's common to all good psychiatric mental status exams. There are problems that at least we face, and that maybe if it's not in Brazil soon, it will be, which are electronic medical records where you pull down and get a checklist. And basically a checklist will say hallucinations, yes or no, and you click. And there's no nuance, there's no subjective analysis, but insurance companies love it and billing agencies love it. And so it's become more and more prevalent here, and it's a real problem because it totally distorts a good psychiatric evaluation, or at least the recording of the evaluation. It makes it like a caricature of itself. And the other point I would like to make are that hallucinations are the most difficult, I think, and the least helpful component in making the diagnosis of schizophrenia and other disorders as well. And we'll get to that, to why over the next few slides. First, a couple definitions, just so that we're all on the same page in how I think about things. Psychosis is thrown around, and it really means three slightly different things. To the lay public, it usually means something like crazy or really abnormal. In a psychoanalytic tradition, and sometimes used by others as well, it has the meaning of being detached from reality versus someone with neurotic symptoms who is not detached from reality. And then the third definition, the one which I'm going to be referring to whenever I use the word psychosis, which I try and avoid, but it's pretty hard to, particularly when my clinic has the word psychosis in the middle of it, that it's somebody who has, it is a state in which someone has hallucinations, delusions, and or disorganized thought or behavior. Sort of the more narrow technical definition of psychosis. First episode psychosis is also a problematic term. It's generally used for individuals early in the course of their illness or treatment that have a psychotic phenomena. Exactly when an episode begins and ends and what makes something first episode is, I think, very difficult and really is not addressed much in the literature. And a better term really would be recent onset psychosis. Even then, the diagnosis when referring to first episode psychosis is left ambiguous. Some use it to mean purely recent onset schizophrenia, but others use it more broadly to include mood disorders and potentially a few other odds and ends of diagnoses in which psychotic phenomena are common. And so we got to watch out for the terms. Though I think fortunately, most of the time it's pretty self-evident what is being referred to, even if we don't know exactly what definition a particular clinician or investigator is using. I want to bring up this issue about first episode psychosis as conceivably a diagnostic fad, or at least ask that question. We know that fad diagnoses have been a plague in the history of psychiatry, where some idea becomes prominent and then is debunked. Some of the ideas are incredibly absurd. Some of them are controversial. Some of them are just an overused diagnosis. Some are just diagnoses that are uncertain. Recovered memory became a major issue in the United States, to the point where therapists were at times convincing their patients that they'd been victims of satanic rituals in early life, and all stuff that was one for which there was no evidence whatsoever objectively that it happened, and that which was really preposterous. Same thing with alien abduction. There was a guy at Harvard who became famous for his gradual belief that a lot of his patients had been abducted by aliens into their spaceships. And I don't think he was using it metaphorically. I think he believed it. He sort of disappeared. Maybe he was abducted. ADHD, of course, is an important diagnosis, but one where the boundaries are difficult to ascertain and where environmental situation is so critical to the diagnosis that it can be used in a sloppy sort of way. Childhood onset bipolar disorder is another one of these conditions that at times is used in rather questionable ways for a kid who's cranky or irritable. But on the other hand, there probably are cases of childhood onset bipolar disorder. The bottom line is that we, as a field, I think, have an obligation to be careful. The faded picture in the background is of one of my most important mentors, a psychiatrist named Paul McHugh, who took this issue of fads very seriously and was constantly teaching us to challenge what we know and how we know it, so that we don't end up driving the field in an absurd way, or a way in which there's no empirical evidence, and in which treatments are worse than the condition. So, and you can see the citations of first episode psychosis have continued to soar over the last 20 years or so. And does that make it a fad? Maybe not. Maybe it's just because we've now begun to pay attention and recognize that it's very important to intervene very early in the course of schizophrenia, and that it may be possible to improve care by interventions. And the citations, the literature in the field is reflecting efforts to make better diagnosis and to make better treatment recommendations. Time will tell. There's clearly, though, a dilemma here, and it's really the dilemma of sensitivity versus specificity. It's pretty clear that prompt treatment of first episode psychosis improves short-term and probably long-term outcomes. There's abundant evidence for that, and there's something just common sense about that. If one captures a patient early in their course, it becomes much easier to help them return to their life course, or at least as close as possible, than after waiting for years when they've gradually lost relationships, lost the chance for education, lost the chance for getting into the employment pipeline early. On the other hand, the wrong diagnosis of schizophrenia is really what I'm thinking about here, but it could be of a mood disorder as well, has big consequences. The medicines that we use have nasty side effects. There's a stigmatization problem. Patients can assume the sick role and end up not progressing even in their life, even though they have the capacity to do so. And if we make a mistake, we may miss the treatment for what the patient actually does have. So I'll give you an example of a case that we saw. This is a 20-year-old woman who's at a prominent university, not ours, referred by her parents to our clinic for a second opinion about the diagnosis of schizophrenia. She was intelligent. She was a good student. She had a lot of friends. She was an extremely successful athlete, potentially at a professional level in her sport. She had lifelong anxiety, like she'd vomit before competitions and was really needed very close support from her parents. No significant substance abuse. She's studying for an exam at the university where she has a roommate, and she has a panic attack. In the middle of the panic attack, she tells her roommate she's hearing voices. There's no other psychotic symptoms. There's no disorganized behavior. There's no functional decline. She's taken to an emergency room. For reasons that escape me, the workup was for inpatient EEG monitoring, looking for some form of seizures, which was negative. She has a couple of more panic attacks, again complaining of hearing voices during the attacks. So she's referred for outpatient treatment, and she's placed not on one, but 2 antipsychotics, which does help her anxiety, no question about that. But there she is, somewhat slowed, which is not good for her career. And even worse, she begins to tell everybody that she has schizophrenia, and she uses that diagnosis to explain all of her life situations, all her normal life ups and downs. It becomes her life story. Her parents don't think she has schizophrenia, and that's why they referred her for a second opinion. And we evaluated her, and what's pretty clear is that she has some form of anxiety disorder with panic attacks. She does not have schizophrenia. Her psychiatrist, somewhat reluctantly, tells her about this, and she's really upset that she does not have schizophrenia, which is probably diagnostic in and of itself. And I don't have good follow-up, but I think her treatment, I think things have gotten better, and that she hopefully has treatment that's focused on her anxiety, not on her having an all-encompassing disorder like schizophrenia. I should say we published a similar case, and you'll see some familiar names here, of a similar sort of patient where anxiety was misconstrued as evidence for schizophrenia in a very kind of similar situation. And this is a case where we know after the diagnosis was changed to anxiety, the patient improved greatly because treatment was then oriented towards her anxiety disorder. We looked at a case series of patients who came to our consult clinic for a second opinion. Of these patients, we were able to figure out that about 54 of 78 had diagnosis prior to seeing us of schizophrenia, something in the schizophrenia spectrum, or at least an unspecified psychosis. We found that 46%, about half of these people, did not have schizophrenia, and instead had disorders like depression, anxiety, bipolar disorder. Of course, as a selected bias sample, these are people coming to us for a second opinion. And it's not meant in any way to be epidemiological, but it is meant to say that it is likely that a number of individuals are misdiagnosed to having schizophrenia when they actually do not. So why does that happen? What are the common causes of what we might call pseudo-schizophrenia? These are the contexts that lead patients to describe symptoms that can be misinterpreted as schizophrenia. One are, of course, disorders that can mimic schizophrenia, and I'm excluding identifiable causes like dementia syndromes or delirium or other neurologic findings here. Obviously, it's mood disorders with psychotic phenomena, and often autism with odd behavior, which is quite difficult at times to distinguish from schizophrenia. And there's an overlap in various ways as well. And people with autism can develop schizophrenia or schizophrenia-like syndrome. So that's pretty tricky. More problematic even is a misinterpretation of phenomena in anxious or distressed patients, like the case example I provided. Patients have vivid thoughts that they interpret as voices. Voices may be used sometimes as just a general term for distress. And I think that's become more common over recent decades as the idea of voices is permeated at least the US, and it's a signal to others that something is wrong. And of course, we have problems where societal fears are misinterpreted as delusions. You know, the idea the CIA is listening in. Well, the problem is the CIA probably is listening in. And anyone with a cell phone, you know, are we being tracked through our cell phones? Probably. I don't think that that's much of a delusion or even a conspiracy theory. And of course, there's always the problem of malingered symptoms, people who say they're hearing voices to get something like being admitted to the hospital to escape some situation or whatever else gains they're trying to make. There's some common contributors behind the scenes to this pseudo-schizophrenia. Individuals with intellectual disability, and I think partly because they may struggle with the right terms to use in describing their interior state, and behavior can be difficult to identify as deriving from psychotic phenomena as opposed to frustration in an environmental setting. As mentioned in our case study, panic and other anxiety disorders or depression where there's very, very intense emotion. Individuals with histrionic or related personality disorders who may have some form of hallucinations, but it doesn't seem to be the same, or may again have these vivid thoughts or vivid and powerful emotions, which they interpret as hallucinations or which emerge in some other way as a psychotic phenomena. And individuals whose social network has collapsed and are in a desperate situation. So distinguishing these things is difficult. Of course, we have to do a rigorous mental status examination being wary of suggestibility of some patients, and we really need the lifetime history from outside informants. And I think what I should have said is C is it's the overall pattern of the gestalt, if you will, of someone's presentation. It's not any one symptom that should ever make the diagnosis. And that's I think, generally true in all of psychiatry, distinguishing a symptom from a diagnosis. So my conclusion is that phenomenology, as established by history and mental status examination, remains crucial for distinguishing psychotic disorders from non-psychotic disorders, but it's difficult and problematic, and sometimes one is left uncertain. So then we can turn potentially to objective measures, including genetics and imaging. Can that help? So let's talk about the genetic workup for someone with a new onset of a schizophrenia-like syndrome. Each one of these issues could be an entire topic itself. So this is meant to be a very general overview. First of all, there's genetic testing for drug metabolism, which is widely available for us, and I suspect in Brazil as well. Just looking at various forms of metabolic enzymes, which is sometimes of value when you're wondering if why a person is sensitive to a particular side effect, lack of response of a patient to a typical dose of a medicine. The problem that we encounter is that these tests are often way overinterpreted, so that if the report says this person is a hyper or hypometabolizer of a given drug, clinicians have tended to say, okay, then we can't use that drug, which of course is not the correct interpretation. All it means is that the dose may have to be adjusted. And even then, metabolism is only part of the game, because we know that while there's large variation between the dose given and blood levels of various drugs, there's also a huge variation between blood levels and clinical response. So this only partly helps. How about genetic testing using SNP arrays? So these are the microarrays that scan across the human genome, looking at variations in DNA, not at this point for detecting the variations themselves, but looking for regions where there have been chromosomal deletions or duplications. And these SNP arrays can be readily ordered. They're used quite commonly, if not universally, for in genetics clinics. How about our use in patients with new onset schizophrenia-like syndrome? One clear use is if there's suspicion of the 22q11 deletion, also known as velocardiofacial or DeGeorge syndrome, which may account for up to 1% of cases of schizophrenia. The rationale for testing is not so much that it will change the treatment for schizophrenia, but that this syndrome includes medical comorbidities, certain metabolic problems and cardiac problems in particular, and there's implications for genetic counseling. The dilemma is, should we do routine screens given the frequency of this condition in schizophrenia and the lack of any but experts to reliably distinguish patients based purely on their dysmorphology, their subtle facial abnormalities? So in the US, the cost for this test is about $1,000, maybe a bit more sometimes. We can sometimes have it covered by insurance, not always. And we have debated at this point whether we should now be doing routine screens. And we don't have a resolution for it, so it remains to us a dilemma. Another indication for this sort of array, and also for specific testing of specific genes, is suspected autism, since there's now a number of genetic factors that have been strongly associated with autism and which might provide a useful way of conceptualizing a particular patient. The clear indication is generally if a patient has psychotic phenomena and something else, dysmorphology or some medical oddities, neurologic problems, or cognitive evidence of a multi-system disorder. I should have given a citation for another paper that Dr. Gedelha and I worked with a resident from FESUP on, where a patient had a genetic mutation that caused abnormal eye movements and visual impairment. And the patient also had a number of psychiatric phenomena, including a psychotic-like syndrome. And our paper explored the complications and the interrelationship of his genetic disorder with his psychiatric disorder, concluding that there might or might not be a biologic basis for the that the genetic mutation causing the eye disorder might also affect his brain function, but it was a big social factor because the patient had impaired vision and because it existed in multiple generations of the family, perhaps leading to a downward drift for the family, which really struggled. So we found pretty frequent hits of finding genetic mutations of our patients who had this kind of combination. It's people with atypical schizophrenia, if you will. And I think it's worth considering obtaining this kind of analysis for such patients. Genetic testing may soon become more valuable. And here, this again is another large topic. Each point would be another whole lecture. I suppose anybody's interested should sign up for the International Society of Psychiatric Genetics meeting in a week or so and see what the latest is. There clearly are now rare variants, occasional mutations that occur only very rarely in the population, but if they occur, the chance of an individual with that mutation having schizophrenia is very high. There is something known as the polygenic risk score, which essentially is taking all the minor variants throughout the genome and summing them up in a way that has been that's established enough so that you can use that sum to figure out the likelihood of someone developing a specific psychiatric disorder. That one's getting pretty close to being clinically useful. It's not quite there yet, I don't think. And then one can begin looking at specific risk variants that contribute only a tiny bit to risk, but which may fall in specific pathways. And that if you have enough risk variants in a specific pathway, then you would likely develop schizophrenia. That's more speculative, but is one direction where the field is moving. So this, I hope, will begin to emerge over the next 10 to 20 years. But every time I make a prediction about when something will change in our field, it's always slower than we think. How about imaging and the workup of psychosis? I give you here the example of SPECT scans. It turns out in the United States, there's a number of there's clinics throughout the country led by this guy. Who knows, maybe he even has clinics in Brazil. I hope not. What he does is do SPECT scans, and he charges a few $1,000s for. And he says they can help him diagnose anything, basically. We know that SPECT scans are pretty useful for various kinds of dementing disorders, but they're not useful for schizophrenia and other psychiatric conditions. And I've read some of the reports on patients that are provided by a SPECT scan, and it reads kind of like, well, a horoscope might be the kind you might read in a newspaper, where it's so vague it could apply to anybody about anything. Your SPECT scan shows some abnormalities in your frontal lobe, which suggests you might have some difficulties in certain environmental situations of making decisions. It's just not clinically valuable, and it's a scam, unfortunately. On the other hand, we do have a real dilemma, and that's the use of clinical MRIs and when to do them and when not to do them. So I give you another case history from one of our experiences. So the father of, who's a well-meaning internist, of an 18-year-old girl with a 1-year history of absolutely typical schizophrenia, asked for a second opinion at our clinic. As part of our evaluation, we asked that she obtain a head MRI scan, and the scan shows a small subarachnoid cyst. Now, radiology reports, at least in the US, and I've been in Brazil, always say something like clinical correlation advised, which is a radiologist's way out of, well, responsibility in some ways, because of course clinical correlation is important. So that doesn't help. The first neurologist they see says, this is an incidental finding of no consequence. The first neurosurgeon, same thing, no consequence. The second one, no consequence. But you keep going, you'll find someone who says, let's operate. And it's kind of thing it's sort of like doing research, and you keep trying. When you get data and you're not testing an a priori hypothesis, you keep finding something until you get something that fits your data, and ultimately that kind of gets you into trouble. So the neurosurgeon puts a drain into this cyst, but it becomes infected. The patient develops a bacterial encephalitis. The good news is it resolves without consequence with treatment. And her schizophrenia doesn't improve until eventually the father was persuaded that this patient should just get a standard course of an antipsychotic medicine, and then things went better. So this is the problem of false positives in obtaining MRI scans, where we induce basically an iatrogenic problem ourselves. And there's an interesting large-scale study about this from about 10 years ago. So they wanted to compare, this is Summer et al. Their goal was to compare MRI-detected neuropathology in patients presenting with psychosis compared to matched controls. They did routine MRI scans. You can see there's about 700 or so patients and 700 or so controls who are age and sex matched. And diagnosis were mostly schizophrenia and a few other odds and ends of conditions. A majority of them are early in their course. The MRIs are read by a blinded neuroradiologist, and the findings are classified as relevant or not. This is what they found. You look at the patient group, 11% have some sort of abnormality that was enough to attract clinical attention. And you look at the control group, and they also had about 11% of subtle abnormalities. No difference, and there was no difference in the abnormalities in patients who were early versus later in their course. And there was no evidence in any of these cases that there are lesions related to their psychopathology, though that, of course, is pretty difficult to determine. So they conclude, this study suggests that it is not essential to perform MRI brain scans as part of the routine screening for psychotic patients. Okay, so this is the argument. Scans are problematic because the yield is likely to be more on the line of false positives, which can have pretty negative consequences. On the other hand, there are counterexamples. And the literature is full of these. I just picked out a couple. This first was a 9-year-old boy who began to have behavior problems by age 3, all sorts of diagnoses and various medicine trials, then auditory hallucinations, bizarre behavior, normal physical and neurologic examination. So an MRI is obtained, and it shows a third ventricle tumor. And the neurologist, this is the other way around. The neurologist says psychiatric status unrelated to tumor. First opinion, neurosurgeon unrelated. The second neurosurgeon says, well, we'll operate. They resect this choroid plexus papilloma, and the patient almost totally resolved symptoms. I cite this in part because this is a well-known Hopkins neurosurgeon who gave up his practice of surgery to become Secretary of Housing and Urban Development in the Trump administration, for which his only real qualification was that he owned a house. This is an agency controlling hundreds of billions of dollars in planning and housing in the US. So most of us think he should have stuck to his day job as a surgeon. Sorry, Ari, I said no politics, but I had to slip. I give you another example, this time in an adult. So this is a 26-year-old man with no past psychiatric substance abuse or medical history. He develops 8 months of auditory hallucinations and grandiose delusions, some violent outbursts. He's not delirious. He has some headaches. A neuro exam was done, and he did have papilledema, but of course that required somebody who was sufficiently attentive to do a good neurologic exam. And his CT scan looks horrible with this big enhancing mass and ventriculomegaly. It's a neurocytoma, and everything resolved after his surgery. So that's pretty impressive. How do we resolve this? What are we going to do? This is a common problem. What do we do now? One is clearly obtaining a scan for some atypical presentation, whether they're neurologic signs or symptoms, which speaks for doing high quality neurologic examinations of our patients with new onset of schizophrenia-like syndrome, atypical age, excessive cognitive impairment, etc. If the presentation is typical, I don't have an answer for whether to get MRI scans for now, and I think the field is split, and it'd be interesting to hear everyone else's opinion later. In the near future, there is a hope moving forward, and that's going to be with quantitative imaging. And I give you a few examples. The one is thalamic cortical connectivity measured by fMRI, and the lead study here was done in 2015 in a consortium called the Naples Consortium, which stands for, it's a group, I can't remember what it stands for, but it's a 7 or 8 sites in the United States investigating people who are at high risk for developing schizophrenia. So they did resting state fMRI scans of people who seem to be at risk for high risk of psychosis, and there's a number of criteria for that. 21 of whom later converted to a full-blown psychosis, which I think they mean schizophrenia, and had healthy controls as well. What they showed was that in those individuals who eventually developed a psychotic disorder, there was increased connectivity between the thalamus and the sensory motor cortex, and a decreased connectivity between the thalamus, prefrontal cortex, and the cerebellum. Individuals at high risk who later converted had greater abnormalities of connectivity than individuals who were at high risk but did not convert, at least not convert yet. And they were in turn had more abnormalities than controls. And you can, let's see, this figure kind of gets at it. On this axis is essentially the amount of brain that's high or low connectivity. And this is looking at the thalamus to the sensory motor cortex on the left. And so here in control individuals, on this axis is essentially higher is positive, to the right is positive, meaning more connectivity, to the left is less connectivity. Controls are have somewhat lower connectivity between the thalamus and the left sensory motor cortex, and individuals who later developed schizophrenia are clearly shifted to have higher levels of cortical, thalamic cortical connectivity to this particular region of the cortex. Similarly, the same group looked at structural MRI, looked at cortical thinning as a prediction of later psychosis. Same patient population, but looking at measures of cortical thickness in various frontal regions, and found that those at risk who later developed psychosis had a steeper decline in cortical thickness than individuals who do not develop psychosis. And you can see on this slide, you can see the frontal regions here that thin the most. And a number of these regions have been commonly implicated in schizophrenia. The details aren't so important, but the fact that in a large patient population, you can begin to see trends both with connectivity and its structure as ways of predicting future course of illness is important. We did a small study of spectroscopy using a 7 Tesla ultra high field strength MRI scan, and large scatter. But what we found is that in individuals with early in their course tended to have higher levels of glutamate that declined over time. And there's been lots of other studies, and this finding itself is been confirmed and then refuted at various times. It's not the result that's important, but it's the idea that there are measures of specific metabolites, in this case, the obviously important one of glutamate, that may also provide some indication eventually of individuals' future course. Another way of looking at the brain is arterial blood volume. Again, a study that we did here. And it's based on Dr. Junwa's description of a kind of way of using an MRI scan to get at arteriolar blood volume. And arterioles are the main supply that's plastic to the brain. And so isolating down to their blood volume is a nice way of getting at blood flow through the brain. And the finding was really crystal clear that there was a diffuse decrease of arteriolar blood volume in people with schizophrenia compared to controls, which was interesting to us because we also run a Huntington's disease clinic, and the finding was exactly the opposite in individuals early in the course of Huntington's disease, where there was an increase in blood volume, suggesting that our measures are not artifactual, but that there's some disease difference in the way that blood volume is regulated in people with schizophrenia. Whether that is a primary problem in vasculature or whether the vasculature is reflecting other issues relating to either neuronal or glial cells is not made by this. We can't distinguish that using this finding. Again, the point is that there are ways going forward that suggest quantitative approaches to imaging may be valuable in sorting out patients from controls and potentially even in a prospective way, though our data didn't address that issue. So the goal is to get single subject prediction of disease state by imaging. All the studies I've shown you are relatively large populations of patients. And the same thing, you know, the classic finding in imaging is large ventricles in patients with schizophrenia. And that's quite a robust finding, but you need 10 or 20 patients and 10 or 20 matched controls to be able to demonstrate it. but you can demonstrate it every time. The problem is there's too much variability on an individual level to use that kind of measure as a diagnostic procedure. So the goal is to develop algorithms based on data from large populations to predict the diagnosis course and most beneficial treatment strategy. We're not there yet. So that's going to be the future of imaging. Hopefully to develop levels of the individual, at the individual level, algorithms that can be of value in determining diagnosis and course and ultimately treatment responsiveness. All right, let's talk about treatment dilemmas in recent onset schizophrenia. So we know that antipsychotics work, but not perfectly. This is a measure of effectiveness, essentially, effect size. 0.3 is small, 0.6 or 7 is kind of medium. Up here is a pretty good size effect. You can see clozapine up here and the others all overlapping tightly otherwise. If we looked at medicines for psoriasis or rheumatoid arthritis, the error bars would be tiny. The goal would be 95% reduction of symptoms in 95% of the patients would be the criteria. These are using biologic agents that block very specific points in the enzymatic pathways. And the effect size would be way off the chart here. It's just showing where we have to go as a field, the extreme difference of where we are versus where the field like rheumatology is when there are specific targets. And we also know, of course, that negative and cognitive symptoms do not respond very well to medicine, so a little bit. We know that social interventions are powerful. This is an old study showing that patients relapse much less if you institute various forms of social skills training or family treatment. That also is not very radical or new kind of thinking. So we know that adherence is a big issue. And here's our dilemma. It doesn't matter how well a medicine works if the patient doesn't take it. It doesn't matter how well a therapy works if the patient does not engage in it. And non-adherence to antipsychotic treatment in schizophrenia is common. Here's a sampling of the literature. And it's high. No one needs to really, everyone knows this is obvious to any clinician. We did a survey in our inpatient unit to see why patients were admitted, and about 80% or 85% were admitted because they'd stopped taking their medicine. So it's a huge issue. It's everywhere. And the effect of non-adherence with antipsychotics is problematic. It's relapse. There's dozens of studies like this. I pick out an older one here of 104 patients who responded well to treatment after the onset of a schizophrenia-like illness. And the total relapse rate is high at the end of 5 years, 82%. The best predictor was not taking medicines. There's lots of things that, there's a few odds and ends of other predictors, but that was the key one. Not all, there's all sorts of other things that didn't correlate. This is the big thing, a risk of like 5-fold higher. What's the best predictor of non-adherence? It's simple. It's non-adherence in the past. Here's one particular study from a drug company, but I think the point is pretty clear that prior adherence had a 79% level of accuracy in predicting future adherence. And there's other factors that one could imagine are involved, but this is really the key thing. If someone comes into our unit and they have an inpatient unit because they've stopped taking their medicine and got sick again, if we go and do the same thing, put them back on their pills, the same thing is going to happen. So here is how I think about non-adherence. And it turns out Dr. Gedelha published a paper. We hadn't talked about it, but we came up with almost exactly the same kind of factors and even organized similarly. So I view patient-centered factors. There's the passive factors. A patient forgets or they're confused, or they're apathetic, which is common in schizophrenia. They're active patient-centered factors where they want to avoid side effects. They believe that a medicine is not helpful, or they have a general mistrust of any kind of treatment at all. And then there are environmental factors like cost of treatment or access to treatment. So how do we address adherence? The obvious one is first, persuasion and a good therapeutic relationship, simplifying regimens so that patients take as few pills as possible, once daily dosing, supervision of medicine, the family member or other care provider helps the patient out, monitoring adherence, and there's rating scales and electronic means. It's easy to be fooled, the evidence says. Keeping doses low, dealing with side effects, and of course, switching when necessary and maybe proactively to long-acting injectable medicines. There's even the latest thing, I think this is available in the US, where aripiprazole has a little chip in it and you swallow it and your stomach acid dissolves the pill and it sends, when it hits the chip, there's a little ping that's sent out. And if the patient's wearing a sensor like a watch or something, the signal can get relayed to the doctor that the patient has in fact taken the pill. This hasn't caught on very well. It's a curiosity. Might be good for drug studies though. All right, here's the long-acting injectables are really critical in providing care for individuals, particularly early in the course of schizophrenia. Here's the fear. One is once it's in, you can't get it out. And one worries about oculogyric dystonia, and the other fears the patient won't take it. The reality is after you give an oral agent for at least a handful of days and the patient's tolerated, most patients will do fine with a long-acting injectable. Patients quickly learn to accept the injection after you can persuade them for the first shot or two. And it assures that the patient's seen in the clinic every month or so, depending on the particular agent. And it really helps to take pressure off of families who are often fighting with their ill relative to get them to take pills. And this just takes that off the table. And I think that's a really underrated benefit of long-acting injectable medicines. I mean, the effectiveness is pretty stunning. Here's one particular group that did a randomized trial of risperidone and looking at on the y-axis the proportion of patients who relapsed. These are the people who were taking pills, relapse rates 50% in about a year. People on the long-acting injectable relapse rate about 5% in a year. It's really remarkable. There's a lot of other studies mostly coming to this conclusion. The ones that do not come to this conclusion are generally studies where it's not a real world sort of study, where patients receiving pills are seen very intensively and their dosing is monitored, and they've been pre-selected as patients willing to cooperate. All right, so that's the dilemma of long-acting injectables, and the answer is quite clear that long-acting injectable medicines are a great tool. It would be another discussion to talk about which agents, and they vary from country to country. For us right now, the leading agents are paliperidone and aripiprazole. Some patients still get long-acting fluphenazine and haloperidol, but less. And sometimes risperidone, but right now that's mostly available as an every 2-week injection. And olanzapine given once a month is generally not feasible because of requirements to monitor patients for several hours after their injection to make sure they don't get a sudden influx of medicine that leads them to become stuporous. The next dilemma I want to talk about, how are we doing with time? We okay? I'm going to assume, Ari, give me a thumbs up or thumbs down. Okay, so let's talk about clozapine. And here the dilemma is our best medicine is also our worst medicine. Clozapine is clearly the most effective agent after failure of other antipsychotics. The conventional wisdom is after 2 good trials of another antipsychotic, go to clozapine. And there's lots of examples. Here's one of them where a trial where individuals in the first episode psychosis were treated with standard medicine, 75% responded. At the end of the day, non-responders ultimately responded at a quite high rate to clozapine. Some have even argued that clozapine should be a first or second line treatment option, that we shouldn't wait. But the problem is the side effects are intimidating. And there's, of course, this long list of sedation and hypersalivation, enuresis and dry mouth, et cetera, et cetera, et cetera. Seizures, agranulocytosis, which actually has not been a major problem throughout the world in recent years because of intense monitoring. Myocarditis and constipation are probably bigger problems. Also orthostatic hypotension and patients fainting when they stand up. But despite all these issues, most patients tolerate these side effects and do well. And there are effective strategies for minimizing many of the side effects, including careful monitoring. Clozapine is greatly underused. I give the United States, I'll bet you it's the same statistic in Brazil. The estimated need is 20 to 30% of people with schizophrenia, but the rates are really, really low. A fraction, a quarter or less of patients who should be receiving it do receive it. And which is why some states are higher than others, is some oddities of, in part, mental health treatment availability, and will change over time. So what's the resolution of the clozapine dilemma? The answer is that if a patient isn't doing well, they're owed a trial because it can turn people's lives around. Designated clozapine clinics, we've found, increase its use so that you have clinicians who are used to the side effects and can work with patients carefully about it and know how to change the dose and how to restart it if the patient stops it, and the usual kinds of issues that come up with clozapine. Our goal in the future is to identify patients who will and will not respond to clozapine. Fred Nucifora, one of our faculty members, is leading a multi-pronged effort to try and address this issue by looking at imaging parameters, biospecimens, and a variety of clinical and cognitive factors to see if we can identify people who will do well with clozapine versus those who will fail, particularly individuals who've already failed other medicines. And I'm hoping that that kind of evidence from us and others will increase the confidence of clinicians in using clozapine if you can safely say to a patient or their family, this medicine is likely to work, rather than let's just try this medicine, which may or may not work in you, but which has side effects. So I want to turn now to some of the dilemma of classification for patients. We have these fundamental distinctions among psychotic disorders that are based on the clinical phenotype, which has proved only partly successful. And we know that it's difficult to make diagnosis. The distinction between schizophrenia, schizoaffective disorder, and bipolar disorder with psychotic symptoms is, I would argue, cross-sectionally impossible sometimes and longitudinally a challenge. We need to come up with better ways of classifying our patients that do not rely on purely subjective measures. A little aside about the DSM. This is the DSM, we're talking about the DSM-5. It's originally, DSM was developed to seek reliability back to the early days of DSM, particularly DSM-3. It's not necessarily, the goal was not necessarily validity. And the goal was to be atheoretical about etiology. And these are criteria developed by committees. So this is not a Bible, even though it's used as a Bible by insurers, by sometimes by investigators, and sometimes by patients, but it's not a Bible. It's a current working way for people to be on the same page and talking about disorders, and shouldn't be reified. So we view it as a field guide to birds, in which all classification schemes are based on black and white photos at low resolution. What you can see on the outside, which doesn't necessarily correlate with underlying etiologic classification. So in DSM-5 terms, you can see these shadowy figures. They all are three large flying creatures with wings, head, and tail, which are probably birds of some sort. All right, hopefully we can get more clarity. So we get an albatross, we get a bald eagle, and we get a B-2 bomber. And it's only by knowing the finer grain and really the workings inside that allow us to make these sort of distinctions. So we don't have just shadows. So that's kind of the side issue. This reasoning comes again from my mentor, Paul McHugh. So I want to talk about the BSNP project, one that I was not involved with, but which I feel very fondly about. I like what they've done. Their goal is to use neurobiologic measures to better classify patients with psychosis. So they took probands with either schizophrenia, schizoaffective disorder, or bipolar disorder with psychosis based on, at the time, DSM-4 criteria, and a lot of them, hundreds, 700, their relatives, and a few hundred matched controls. And they used what they called a biomarker panel, which included neuropsychological testing, various measures using eye movement of how a person responds to start and stop signals and how they control their eyes, and auditory stimulation paradigms, essentially auditory evoked responses. And their goal was to use these measures to reclassify the probands, and then later to validate their reclassification scheme. They came up with 3 biotypes. They lumped, remember, this is lumping all the patients with schizophrenia, schizoaffective disorder, or bipolar disorder with psychotic features together and reorganized. Biotype 1 are people who tend to be chronic, deteriorated, poor outcome cases. They have profound difficulty with cognitive control and decreased sensomotor reactivity. Biotype 2 are people who have a moderate level of cognitive control dysfunction, but increased sense. 3 are less severe clinically on average, are nearly normal cognitively, and also have nearly normal sensory motor reactivity. And so this isn't a linear continuum. These are qualitatively 3 distinct types of patients. We'll skip that. Here's what the data looks like. You look at cognitive control measures, how well an individual is able to redirect various stimuli. Biotype 1 does terribly, biotype 2 does intermediate, biotype 3 does about the same as controls, which are the H. Relatives are the same as the relatives of biotype 1 and 2 and 3 are the same pattern as their affected relatives, but less severe. Sensory motor reactivity shows a very different pattern. Again, biotype 1, very low activity. Biotype 2, overreactivity compared to H, which is control. And biotype 3, about normal. And relatives match the probands, again, at milder levels. So here's how the redistribution looks. This is a scale they called the schizophrenia bipolar scale. These are individuals who look more like they have schizophrenia. And the triangles are people who were diagnosed with DSM with schizophrenia. The crosses with schizoaffective disorder. The orange dots are people with bipolar disorder with psychosis. And while there's some skewing of biotype 1 towards schizophrenia and some skewing of biotype 3, the least affected on their measures with bipolar disorder, you can see that the clinical diagnoses fell across all 3 biotypes. So it really did reorganize how individuals, how the diagnostic constructs worked. And it was validated, and I don't think I'm going to go into details here, but it was validated with imaging data that corresponded to the biotypes. And it also, the biotypes corresponded to social function as well. So here are the implications. One is that it is possible to improve on our century-old classification scheme by using probes of brain function. To do this, it was important to have large sample sizes. The third point is that this study is just a start. Different kinds of probes might yield different and potentially better classification schemes. They use neuroimaging as a validator, but you could imagine that neuroimaging could be used as a classifier. And these improved classification schemes have immense potential. Better predictions about early psychosis, improved search for etiologic agents, genes and environmental, and improved clinical trials. So I just want to summarize for a moment. Diagnosis. Qualitative MRI is problematic. Quantitative MRI is the wave of the future. There may well be other quantitative measures like genetics that will be valuable. Right now, we are reliant on our clinical acumen, and we can be fooled. Treatment, non-adherence undercuts all therapeutic advances. Clozapine and long-acting injectables are greatly underused and extremely valuable treatments now that can be implemented without waiting for new discoveries. Ultimately, a reconceptualization of schizophrenia is necessary. The concept is probably obsolete. There are going to be better ways of classifying our diseases. BSNP providing a model approach to how psychotic disorders can be reclassified, but not necessarily itself being the final answer. So just to wrap up, I want to end on a note of optimism, and I note literally, this guy is Tom Harrell, who's a world-renowned jazz musician. He's considered the leading composer of jazz trumpet music and also a great jazz trumpeter himself. And he has schizophrenia. I've seen him interviewed. Unfortunately, the clip was taken off YouTube. There's no question he has schizophrenia. He also had bad EPS. So sometimes his band members would have to say, Tom, quit listening to the voices and start playing. Or he would sit there with his gross tremor, and then all of a sudden he starts playing and it all kind of goes away. It was really, really remarkable. Of course, it shows, though, the power of environmental support. He was a genius, had exposure, was a professional by the time he was a teenager. His parents were in the music industry. He's married to a very supportive woman, and he's financially well off. So there are factors that are involved in all of this as well. But patients can do well. Schizophrenia is not necessarily the kiss of death, though it's a severe and terrible illness that we need to work to improve. So I think I'll end with that. Let me stop the share.
Thank you very much. Well, in summary, this is, it's a presentation of a really clinician researcher and observing, the main questions we have on treating schizophrenia. All the questions you have raised, for sure, we share with you because, they are so important, and you really give an update of how all the technology we have, genetics and neuroimaging, how can we treat better our patients. But in the end, still the really accurate clinical examination is still one of the best that we can have in schizophrenia. So not yet a very clear help from neuroimaging or genome, not for a daily clinical practice. And in terms of the treatment, I would like to have two questions. One, do you have any, I didn't see any effect size comparing long-acting injectables and clozapine. What is nice for us is that clozapine, we have more freedom to use because it can be paid by the government. But the long injecting is more difficult. Some patients, they can be paid by, their support. But anyway, it's not so easy as clozapine. So we have, and of course, we are exactly aware, as you say, that we have to stimulate more use of clozapine. Is still lots of data showing how underused. So I wonder if you have this effect size comparison between long injectables and clozapine.
I don't think that data exists. And I can tell you that John Kane, who is, many of you may recognize the name, is one of the leading investigators of psychopharmacology, particularly antipsychotics, is launching a trial that ultimately will be comparing an early onset, recent onset schizophrenia, clozapine to long-acting injectable. And so we may get some answers in a real world setting. I think it's a good question. And of course, issues of adherence come up, and it's actually pretty complicated. I think one of his thoughts is, first, we want to make sure an individual has been on one long-acting injectable, and then the next stage of the trial will be clozapine versus a different long-acting injectable, and see if clozapine is better or not.
Sure. Russ, before I pass it to Ari, do you have a family intervention together the program for first psychosis? So do you have a planning for family?
Yes, I think that's a really good issue because that's important.
Sure.
Particularly young individuals, teens and early 20s living at home. Their family is tightly bound with how they're functioning, and the family needs to be educated as much as possible. The family and the patient need to agree to rules. Sometimes it works, things are smooth. Sometimes it's really rocky. Sometimes the parents sometimes have to decide whether they're going to be tough or tender. That is, do you say to their teenager, young adult child, if you don't take the medicine, or at least if you don't behave, including these rules, then you can't stay with us anymore, or we won't support you, or something like that. And that's a very, very difficult situation for families. And that's why it really does involve clinicians, because every family is individual and has different values, and those issues need to be addressed in a very serious way. So that's something that we value very highly.
Very good. Ari?
Thanks, Jaib. Russ, thanks for your amazing talk. Fantastic. It's so important for us to listen to you and to this, I would say, this review of the state of the art of the treatment of schizophrenia. For many reasons, I will try to, because of in sake of the time, for two main reasons. One of them is that here in Brazil, we have this feeling that, well, we cannot treat well schizophrenia, we don't have the resources. So the schizophrenia only can be treated in Johns Hopkins. And when we listen to you into your clinic field, I would say, and your care to the patients, if we sum up all the dilemmas that you put, we can treat schizophrenia as well here in Brazil. If you are good clinicians, if you're aware of what is the best choice for the patients, we can treat them well. Of course, if we have more resources, it will be easier to care for the patients with some specific situations. But I think this highlight for us the importance of know neuroscience, but at the end of the day, to be a good clinician and to treat well the patients with the research that are available. And this is very important for us. And the other that it's very linked, because you're a model for us. Most of the researchers in Brazil, they are clinical researchers. So we do clinics and we do research. It's very difficult for us to be only researchers. Many reasons, most of them related to funding. But in US, you have this model, but it's I think it's the winning model, I'd say, to have the clinical perspective, to be with the patients, to have the clinical practice, and to look for research questions. And then you summarized the points, not only reviewing the literature, but critically reviewing from the perspective of a clinician. And this is very important as well, because sometimes we feel that to be a very good clinician, we need to ask for genetic testing for everyone. We need to do very sophisticated neuroimaging exams. But at the end of the day, although all our enthusiasm with neuroscience, we need to be critical about what is the possibility that this really will help our patients or not. And in Brazil, we have the discussion of asking MRI scans for everyone who presents at the first episode of psychosis, independent of the clinical. And this is not the recommendation. We don't have one single guideline that recommends this. And we are a poor country. And so we need to discuss this critically. Okay, and I feel more confident. And the third, I had the opportunity when I went to Johns Hopkins, thanks to the Patrice and everyone that supported me and Rodrigo to go to Johns Hopkins, to watch your appointments and to see that we can have all the resources, but when we are in the front of the patient, you need to have a good doctor-patient relationship, and this is the art of the medicine and the psychiatry. So I feel very comfortable to talk to you as a clinician, as a researcher. Well, I would do one single question. You know that I'm very interested in treatment resistant as you, and I enjoyed that paper in schizophrenia research that you looked at anterior cingulate glutamate that was elevated. Did you, it's a small sample, but did you find any difference between responders and non-responders to the level of glutamate in the anterior cingulate?
Oh, that's studied way too few people to do that kind of analysis. That was really a methods, testing out new methods. And MRS troubles me some because of the amount of brain region that you need to cover with the voxels to see, to get a signal. And it's, and also, so you get elevated glutamate in the brain region, but exactly what does that mean? We don't know if it's intercellular or synaptic or so I've put that one a bit aside, but there may be ways that technology can be improved and matched with other technologies to improve things. I do want to focus to reiterate your point, Dr. Gadella, about the thinking about things carefully as a clinician, because it's certainly far more important in almost all cases to get a good history, talk with the family, track down as much information about a patient's previous course to figure out what's going on, more important than getting an MRI scan. And just as an example, there are certainly times when an MRI scan is going to be valuable. Most times it won't be, but boy, knowing that the patient was totally well until high school and then fell off and became ill is very different than someone who was always ill, going back to the earliest stages and who struggled cognitively in school. Knowing that sort of thing makes a big difference in treatment, or knowing that the patient had episodes of being totally well since the onset of their illness makes you wonder about what the diagnosis might be. That kind of thing is just critical. And it's time and patience to collect that information. I do see a couple comments. Well, one is about Descartes and mind, basically the idea of dualism, and will that help us advance schizophrenia? And I don't know about that. Whether I think most clinicians and neurologic investigators recognize the mind is emerging out of the brain substance, but that the mind still has different properties, just like a table is different than a plank of wood and four posts. But I think I better leave that one for the philosophers. I think it may be knowing more about schizophrenia may help us understand more about the brain. The other question was a really good one. Why this waiting on clozapine for 2 good trials? Is that too much? Should we be going to clozapine sooner? And I think there's 2 answers. One is there's clearly, even with this guideline, the guideline is not followed very well. We know we don't follow it often. And that individuals do indeed lag many years before a clozapine trial is launched. And so if one stuck more closely with, say, 3 to 6 months of a good trial of an antipsychotic, move on to another one, and then go to clozapine, that would help a lot with the lag time and still keep with the recommendation. I think it is a fair question about whether there's some advantage to going more quickly to clozapine. I think there are a few countries in the world, someone might be able to tell me this, where clozapine is first line, partly because the drug itself is cheap, even though all the testing and all that we've implemented is more expensive. And you can make a case, instead of start the best medicine first, if it has problems, then switch to something else rather than the other way around. I think there's a case to be made for that. But I think we can stick with our current recommendations, but follow them more tightly. Try a couple other things that are easier first, but not delay.
Russ, we are on time now. I would really like to thank you. And really, more than the conference you gave, it's been so important to us, the interchange between residents and offering the opportunity for our residents to know your program at Johns Hopkins. It's been of a great value. So I thank you so much for that. And I pass the final words to Ari, who is one of the heads of our schizophrenia program, which has been helping training so many psychiatrists here in Brazil. So this interchange has been really terrific for all of us. Ari.
Yes, for those who don't know, we had the opportunity to send 2 psychiatric residents in 2019. Our intention was to send more residents, but then the pandemic came and we were not able to send them again. I hope that in the future we can start this interchange program again. And we really need to thank Bruce. The amount of bureaucracy was amazing. He was very kind. He was very supportive for the students. Me and Rodrigo, we had the opportunity, Professor Rodrigo Bressan, had the opportunity to spend some days and to visit the service and to watch the appointments. And this was quite inspiring. I would say that it changed a little bit my perspective here. And so Russ is a good researcher, is a good clinician, it's a good person, very humble, very and accessible. And this is very important. We had the opportunity to talk several times. I always, Russ, I want to know more about your first episode program, the RAISE program. And then he makes a call. He called Krista. I think we had this opportunity to understand how you organize your first episode program. And we are trying to adapt the program here in Brazil. We had several talks about treatment resistant. Russ invited me and Rodrigo to talk in the grand round of the Johns Hopkins. It was a great honor for me. I never expected this. I was very anxious, but it was nice. And this is the kind of opportunity that we cannot lose, because it's so good in so different ways. And I think most of these opportunities, it's because of the personality of Russ, but it's quite a gentle and humble person. Russ, thank you a lot for all this, and I hope that we can have this interchange for many years.
Well, my thanks to all of you for inviting me, Ari and Jair, and of course to Patrice. This interchange has been very valuable for me as well. I've learned a number of things. Ari has guided me on some research ideas, and we hope we can implement them now that we're up and running in a good sort of way. And it was wonderful to have the residents over. You can see they both published papers, and I think they had a good experience, and we enjoyed meeting them. And so it's a wonderful opportunity for exchange. After all, we are treating the same sorts of patients. It's a real challenge, no matter where in the world you are. These are very, very complicated and difficult illnesses. And, you know, we owe it to all of our patients to work together to come up with the best clinical practices that we can and look ahead to where our research can go in the future to improve care.
Vamos abrir as câmeras para agradecer o Russ. Russ, thank you. We keep in touch.
All right. Take care, everybody. Thank you.
Russ, thank you. Good to see you. Beautiful
Thanks,
building
Patrice.
on the back.
And
Good to see you.
Eva Posner was with us also. So we have very nice people around with us. Thank you so much for the audience. So we hope to see you soon, Russ. Thank you.
Take care, everybody.
Take care. Goodbye, everybody. Have a good week. See you guys.